computer. Yalla, Bismillah. Okay. Thank you guys for attending for such a short notice. Today we'll talk about cardiocutaneous disorders, okay? Stimulated by a couple of cases that we had seen recently. Okay, عموما, case one. So this is a patient who presented with cardiogenic shock, distress, pulsating neck veins, skin mottling, hepatomegaly, prolonged cap refill time, and was presented at Al Jahra Hospital. He's like 3 years old, intubated for 10 days. He is a product of consanguineous marriage. The family history was unremarkable, and he had metabolic workup that came back negative, a viral panel that was positive for rhinovirus and Haemophilus influenza virus. This was just in October 2025, a couple of months ago. Obviously, he has cardiomegaly. You guys can hear me? Sahar is unable to hear me. But everyone else can hear me, صح?
Yes.
Okay.
Yes,
Sahar,
yes.
it's working. زين. Okay, for cardiomegaly طبعا ECG. So what do you guys see on this ECG, by the way, really quick? يعني you guys can see PVC, صح? There's a premature
Yes.
Low amplitude QRS also.
yeah, low amplitude. زين.
low voltage وفي
أك-
بي في سي.
صح, ectopy, low voltage. P waves are probably a little bit generous, okay, lead to maybe. والcardiac axis is left axis, صح, negative positive, okay. There is no ST segment changes, there's no pathological Q waves. Okay, I agree with you. Low voltage PVC, at least one PVC that. Okay, Sahar, I don't know what's wrong. Everyone else, the problem is on your side. Okay. Anyway, so definitely abnormal ECG. Okay. Okay, more ECGs. Same thing. PVCs. طبعا couplets here, صح؟ فيعني two back-to-back ventricular ectopy. Okay, طبعا in this case obviously different morphology, صح؟ طبعا this is one morphology, this is one morphology, this is the third morphology, so polymorphic ectopy. Agree, guys? Almost every PVC looks different than the other, صح؟
Yes.
Yeah, left axis remains low voltage. Here, same thing, multiple PVCs. So, for what we learned that he has, maybe a little bit generous P waves, low voltage. Low voltage عادة suggests cardiomyopathy, or pericardial effusion مثلا. Multiple ectopy طبعا could be also related to myopathy. ولeft axis هذا also a sign of cardiomyopathy. Okay, زين. Further ECGs almost the same thing. PVCs low voltage. Okay, here there is a bigeminy like PVCs monomorphic here in this ECG. Okay, so we learned that the ECG is abnormal, the chest X-ray is abnormal, there is cardiac symptoms. So echo was done. Echo shows severe LV dilation, as expected, EF less than 15 with decreased function, طبعا. There is also intramural thrombi. Okay. You can see it here in the LV apex, okay? So the patient was given, this is all in Jahra Hospital. The patient was given IVIG, methylprednisolone, milrinone, and then later levosimendan, without much, with some improvement in function, but not major improvement. Eventually, يعني remained in the hospital for like 30 plus days, and he was discharged on Entresto, spironolactone, Lasix, digoxin, carvedilol, aspirin, and Clexane. Okay. So he was discharged and then eventually came to us with a Holter. Okay. So this is his Holter in January 2026. Remember, he presented in late October. So this was discharged roughly in December and came back in January to us. Okay. So this is on carvedilol and digoxin and the other drugs. He had PVC ectopy of 6% at 6% with, here, non-sustained ventricular run, polymorphic ectopy. Okay. Um, so very abnormal Holter. Okay. Okay. When I saw him in clinic after this Holter, I wanted to change carvedilol. We changed carvedilol to metoprolol, and then we did also cardiac MRI. Cardiac MRI showed epicardial, basal, mid, and anterior septal LV. So extensive fibrosis of the LV, and the EF is, biventricular decreased function. Okay. So LV, RV, EF were like less than 20%. Okay. So now this is in January. After metoprolol, he came back, similar ECG, EF roughly 20%, LV dilated, there's MR. As you can see, the squeeze is barely there, but the intracardiac thrombi dissolved. This is his father ECG, which is normal with a normal echo, and the mother ECG also normal with a normal echo. Okay. Both, I don't think they did Holters yet, but would imagine the Holters would be normal. Okay. They're not complaining. Brother ECG normal, sister ECG is also normal. Okay. Okay. So this is the patient. Okay. So he has a little bit of alopecia. Um, and we ordered obviously genetic testing, by the way, and when we examined the patient, I noted skin thickening in the sole of the patient, onycholysis. His hair is, in the past his hair is curly, and now he has alopecia. And then the genetic testing came back positive for a likely pathogenic desmoplakin homozygous mutation, like homozygous, okay, meaning not heterohomozygous, desmoplakin mutation that was likely pathogenic um, in desmoplakin. Okay. Okay. So, I will talk about what does that mean later. But anyways, يعني in summary, he has cardiac disease, he has skin disease, he has hair disease, and presenting with acute heart failure, with cardiomegaly, with bad function, and frequent ventricular ectopy and non-sustained ventricular tachycardia. Okay, so we admitted him um, um, because of, so eventually, he when we when we were monitoring him, he eventually had a little bit of decreased function, decreased oral intake and a little bit of weight loss. So we did admit him. We started him on Mirinon, we stopped his metoprolol, and then while he's in house, he had frequent non-sustained ventricular tachycardia, as you can see on his Holter. Okay. Um, and these are examples of his polymorphic ventricular tachycardia or monomorphic ventricular tachycardia. So we started him on maxilitine. That improved slightly his ventricular tachycardia burden. And then eventually we added amio, which significantly improved his ectopy, and there's no more ventricular tachycardia runs. Okay. So he is planned for ICD. However, his weight is a little bit small. But because of his recent admission, we want him to be stable before implanting an ICD, because he is, we just started his heart failure medications like roughly late October. So we wanted 3 to 6 months of him being on drugs and making sure his function is not, normalizing, and waiting for him to be stable before implanting an ICD. Okay. Um, with an ICD, obviously we have options. We can do transvenous across the vein, or we can do extracardiac ICD, whether epicardial ICD, meaning you open the chest and implant the ICD on the heart. But this is usually not very attractive option because it's a obviously big surgery, and it's not very easy to implant an ICD epicardially. There's a newer option called extravascular ICD, which is usually done by electrophysiologists. As you can see, this is a cartoon of that extravascular type ICD. So you implant the ICD on the left, chest, and then you tunnel the lead under the skin and then under the sternum. Okay, like this. Okay, so it is minimally invasive procedure that could be done, and the device is not large. Usually this is a very new device and it's not approved for pediatrics, but this is something that we might consider. Otherwise, we'll do transvenous ICD, which is a device that goes across the vein into the heart. Okay, like usual. Okay. Anyway, so this is the plan for him, and because we obviously he should be evaluated for heart transplantation, but this service is unavailable to us, unfortunately. Okay. And then we're pending rest of the family genetic testing. Okay. Family is hopefully going to be trained for BLS just in case. Okay. Anyway, so this is a complex case that maybe everyone knows. Do you guys know this patient?
رقابة.
Yeah. So everyone knows this patient, but
Yes, yeah, we know.
yeah. So far he's on heart failure medications, and in terms of arrhythmias, anti-arrhythmic medication, he's on amiodarone only now. We stopped his mexiletine recently, I believe, and then the plan is for him to assess his function going forward. If there is no improvement in function, meaning it's not above 35%, we would plan for ICD hopefully in the near future. Okay. Okay. Case 2. This is another patient who was referred to us because of irregular pulsations following a viral illness. Okay. Also consanguineous parents, product of consanguineous marriage. His family history is positive. His sibling died at 10 years of age with dilated cardiomyopathy. This was back in India, I think 2023. Just recently, and a couple of years ago, he had congestive heart failure, frequent polymorphic ventricular ectopy. He had severe, biventricular dysfunction with positive left ventricular scarring. But he had otherwise he had normal, skin and hair manifestations, no other, other systems involvement. His so back to the his so the sibling, back to the case, irregular pulsations, but his echo was normal. This is his ECG. So why do you guys think he has irregular pulsations?
BVCs also?
Yeah.
BVCs.
So he has PVCs. Again, PVCs are varying a little bit different in morphology, and relatively frequent, of course, right? So in this ECG, there's a couple of PVCs. This is his Holter. Again, non-sustained ventricular tachycardia seen, polymorphic, very abnormal with a burden of 14%. So this is back in 2024, by the way. I did not see the patient back then. He had this Holter, polymorphic non-sustained VT, and then the patient just disappeared for 1.5 years. Okay. So then now came back 1.5 years later, and now I see him. He's coming back now because he's worried that, the patient, this child doesn't have much symptoms, but obviously his sibling died, and the parents are getting worried that why he had, why did the sibling died, and this brother is also not having not normal cardiac, examination. So now I'm seeing the patient. He has, on his ECG, frequent polymorphic ectopy. Otherwise, there's no pathological Q waves. There is a little bit of RSR prime in B1, but voltages are not, low. Otherwise normal ECG. Okay. So I repeat the Holter. Remember, in 2024, the burden was around 14%. Again, we see non-sustained ventricular tachycardia. Burden is increasing up to 26%. This is in December 2025. So again, recently. Okay. He is started on nadolol. And then came back for follow-up, shortly. And then his repeat Holter showed frequent, again, non-sustained ventricular tachycardia, bad Holter, okay, on nadolol, okay? Uh, so you remember his function is normal, but he's having multiple ectopy and non-sustained ventricular tachycardia. PVC burden remained the same. So nadolol did not do much. So we admitted him to start mexiletine. Mexiletine did improve his PVC burden, now down to 9% with polymorphic PVCs, but no ventricular tachycardia. Now he's on mexiletine and nadolol. Okay, this is his father ECG, normal, mother ECG, normal. And then this is his deceased sibling ECG with frequent ventricular ectopy. So very similar to this child ECG, except that his sibling has had decreased cardiac function, and this patient that we're seeing so far has preserved cardiac function. Okay. At times you can, the PR interval looks generous. The Q, there's a Q waves in lead 2, 3, and AVF. So there's like left ventricular, or sort of inferior scar. There's a little bit of decreased voltage. So, definitely in addition to PVCs, like P waves are generous as well. So there's further pathology in his ECG. Okay. So this patient workup, so we did parents echo, both were normal. Parent Holters, both are normal. The MRI showed extensive scar involving the lateral inferior and septal LV plus RV free wall. We did genetic testing, of course, and it came back homozygous for desmoplakin. So again, homozygous desmoplakin, different mutation, but homozygous, okay? And that mutation is labeled as variant of unknown significant. But there is evidence of disease causing in experimental studies, and it is previously reported in patient with cardiomyopathy, and it's not present in normal individuals. Okay, so it smells like a pathologic mutation. So when you get genetic reports, the report usually label the variation either as benign or likely benign or unknown significance or likely pathogenic or pathogenic. Okay, so when you get a report with VUS, unknown significant, variant of unknown significance, you have to study that variant yourself. And then when we did that, we noted that there's experimental studies in that specific variant that suggests disease causing, and it was also previously reported. So perhaps it's more, towards pathogenic side. Plus, this patient obviously has cardiac disease. Okay. Okay. So obviously, we're not happy with anadolol, so we switched to sotalol. The repeat Holter is not yet done. Because of his, VT and non-sustained VT, his sibling dying, the genetic variant that we saw, probably he deserves an ICD as well. His weight is this patient age is 4 years, so a little bit bigger than the initial case, but also on the smaller side. But he's a little bit better in terms of weight, 24 kg. And then case 3 presented as an adult. This was probably last year, roughly 50 years old, also consanguineous parents. And by the way, case 2, like we said, this patient has no skin or hair disease, okay? Case 3, 50 years old, consanguineous parents. Echo showed severe biventricular dysfunction. MRI showed LV scarring. And he had, skin disease, as you can see, ugly skin disease. And he has a sibling with similar skin condition. This patient presented with frequent PVCs, severe cardiac dysfunction, and he was admitted for what he received an ICD, and then I came to see him because of his family history, unexplained LV disease, and we did genetic testing, and the genetics came back with homozygous loss of DSC2, which is desmocolin 2. So there is no desmocolin gene. There's loss of desmocolin gene in this patient. So these are 3 cases that we met recently that are relatively similar. So now we'll talk about them all together. So there's something called cardiocutaneous syndromes. These are rare autosomal recessive disorders. Okay, it's like homozygous mutations that are clinically characterized by hyperkeratosis or thickening of the palms and soles, woolly hair, and cardiomyopathy. Okay, it is also called woolly hair palmoplantar keratoderma syndrome. Sometimes present as a lethal neonatal epidermolysis, total alopecia, and onycholysis. Sometimes there's predominant skin manifestation. Sometimes there's predominant cardiac manifestation. Sometimes it's a combination of both. Okay? So these syndromes are caused by desmosomal genes. And I'll talk about desmosomal genes in a second. So when you have plakophilin gene mutation, JUP, junctional plakophilin gene mutation. If you have an autosomal, also a homozygous mutation in plakoglobin, you will get like right ventricular cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy with the skin manifestation. This is also called Knox's disease. And when you have homozygous desmoplakin mutation, you'll have predominant left ventricular disease with the cutaneous manifestation, and it's called Carvajal syndrome. Okay? And then if you have desmocolin homozygous mutation or deletion, you usually get biventricular involvement, and the skin manifestations are less common. Okay? So what are desmosomal genes? So sometimes there is absent of skin manifestations, okay? So what are desmosomal proteins? Are proteins that are localized between between cells. These are adhesive proteins responsible for integrity of the cardiac myocytes or skin cells. So this is one, myocyte. This is one myocyte. The proteins that get, in between the myocytes, these are called desmosomal proteins. Okay. So the examples are desmocolin or DSC2, desmoglein, plakoglobin, or which is JUP, or plakophilin, or desmoplakin, which is DSP. Okay. So we had 2 cases of DSP, and we had 1 case of desmocolin. Okay. Are you following me, guys? Well, you're lost. I'm talking a little bit quick, صح?
It's okay. It's okay.
You're good?
It's okay.
Okay. So when you have mutations in such desmosomal proteins, this leads to myocyte detachment. The cells separate apart from each other with subsequent scarring and inflammation. Okay. So these are the desmosomal proteins that connect myocytes together, for example. We named all of them here. And imagine if there is a loss of desmosomal proteins, the connection between the myocytes are lost. And then because there's other stuff in between cardiac myocytes, you will lose the other stuff as well. For example, the gap junctions, the sodium channels, adherence junctions, and so forth. Okay, so it results in significant, um, you know, um, electromechanical dysfunction, and dysfunctional intracellular signaling cascades, and so forth. Okay, so it's usually very disease causing, or the patient's the manifestation of the disease is significant. Okay, so again, if you have desmosomal gene mutations, it leads to obviously desmosomal rupture, reduced cell adhesion, intercalated disc widening, and then there is gap junction, disease. There's ion channel disease, abnormal calcium handling, and cardiomyocyte death, and so forth. So you'll get inflammation, scarring that results in, arrhythmias, and you've got electrical instability also that results in arrhythmias, and then the cardiac death also would result in decreased cardiac function. Okay, so collectively this is called arrhythmogenic cardiomyopathy, meaning there is decreased cardiac muscle disease, or there's cardiac muscle disease, but predominant electrical disease as well. Okay. So when you lose your desmosomal proteins, these are very important. The desmosomal proteins are very important for the myocardium and skin integrity. Okay, tissues that experience constant mechanical stress. Okay, and like this is why palms and soles are mostly affected because of the friction. Okay. Also placoglobin is essential, for example, in hair follicle proliferation, and then the placoglobin is connected to desmoplakin. So if you have desmoplakin issues, your placoglobin is also diseased. So also hair disease might manifest. Okay. So these are very, very rare diseases. Okay. This is a recent paper in 2025 just showing where are all the reports of the cardiocutaneous syndromes. And as you can see, there's no reports from our region, but there is reports from Greece, Italy, Europe, Greece, Turkey, and a little bit sporadic, cases from America and so forth. Okay, so mostly are placoglobin, um, or desmoplakin, but DSC2, which is the green, is very rare. There's like one circle here. So this is the rarest, and NR just means there's cardiocutaneous syndrome, but it's not genetically tested, okay, or reported, at least in the paper. Okay. Anyway, so these are very rare diseases that are localized in specific regions of the in the world. And definitely we have more in this region, but not reported. Okay, so when you encounter a patient with ARVC or dilated cardiomyopathy or non-dilated LV cardiomyopathy, always try to check for the skin and the hair of the skin, and hair of the patient. And if you see skin disease or hair disease, suspect those rare cardiocutaneous syndromes. Okay. Or if you have a patient, طبعا, not us usually dermatologists, with hair or skin disease that is unusual, they have to check for cardiac involvement. Okay. طبعا, if they checked and they found they found ARVC or DCM or non-dilated LV cardiomyopathy, of course they should suspect those syndromes and do genetic testing accordingly. Okay. And if they don't see any cardiac involvement, but this unique skin and hair disease, obviously they need repeated cardiac workup because they might manifest cardiomyopathy later. Okay, but sometimes the skin disease manifests before the cardiac disease. Sometimes they manifest together. Okay, but usually the skin disease might manifest before. Okay. So regardless, genetic testing should be done and looking for plaque of placoglobin, desmoplakin, or desmocolin, okay, mutations, okay. طبعا obviously these patients are very complex. They need cardiomyopathy. They need, cardiomyopathy experts. They need arrhythmia experts and dermatologists and so forth, okay. So, with Nexus disease, the predominant cardiomyopathy is ARVC. LV involvement might be, and this is described, but less likely. And ECG will show right-sided, manifestations. With Carvajal syndrome, uh, the cardiac disease is usually left ventricular. Biventricular involvement has been described as well, and ECG shows predominant left-sided manifestations. Because it's left-sided disease, heart failure symptoms are usually more prominent with Carvajal syndrome, like in our patients, and with desmocolin, usually it's biventricular involvement, or at least left ventricular cardiomyopathy. طبعا ECGs which show signs of both RV, LV involvement, and then it's among the rarest, and then the skin manifestations is less common, okay? These are all very rare. Like the largest paper on Naxos or Carvajal is less than 12 families or 12 patients, okay? So very rare, okay? Usually penetrance is full, like 100% penetrance. There's frequent VT in the young, high mortality, and then they might present with myocarditis like pictures, repeated myocarditis like pictures, okay? So in terms of management, we have to use Dr. Mitwalli expertise for heart failure management, because they almost all of them will develop cardiomyopathy at some point, especially the left ventricular cardiomyopathy for Carvajal or DSC2. Naxos is more right ventricular cardiomyopathy, but in any case, the management is roughly the same. Arrhythmia management, such as medications, but often they are resistant to medications. So as such, they need ICD, whether primary or secondary prevention. Like we said, they have, they have frequent ventricular tachycardia. So you have to be very aggressive with their arrhythmia management. Sometimes you need to ablate. You do need to ablate ventricular tachycardia if the patient has already an ICD but is receiving frequent shocks. Okay. There are risk calculators for ARVC and desmoplakin variants that you can use to risk assess the patient. But like I said, I don't trust medications only for such patients. They are at high risk for sudden death. So most would receive ICD. Obviously, if you have a patient like Naxos disease patient, with an ARVC phenotype, sports restriction specifically is very important for them, and then dermatology referral. Okay, so if the patient is on guideline-directed medical therapy for more than 3 months, okay, and the EF remains less than 35%, he or she would deserve ICD, regardless of the age. Okay. طبعا if the patient had cardiac arrest, sustained ventricular tachycardia or VF, or unexplained syncope, then obviously definite also needs an ICD. Okay. And then, like we said, the ICD could be transvenous, could be epicardial, could be extravascular, could be subcutaneous. So we have 4 ICD types. Okay. Transvenous has issues with extraction of the leads and endocarditis and and so forth. Epicardial has an issue with difficult implant and longevity, usually lead to fractures and sensing issues. Extravascular and subcutaneous ICDs are good options. Subcutaneous ICD is large device, so needs usually bigger patients. And extravascular ICD is a newer option that is not yet approved for pediatrics. So in general, pediatric ICD is complicated. Any option has its disadvantages. Okay. Okay, so this is in brief. I wanted to talk about cardiocutaneous syndromes because for whatever reason, we had 2 back-to-back cases. Both are desmoplakin or Carvajal syndrome patients. One did have so case 1 had LV cardiomyopathy with hair, skin disease. The case 2 had frequent ventricular tachycardia without cardiomyopathy or without hair or skin disease. Okay. And the third case is desmocolin 2, which is the rarest form. Any questions? I don't know how many.
لا شكرا شكرا دكتور محمد.
I feel, Dr. Muhammad, I'm not sure if this is correct or no, but
Yeah.
I feel that some children after viral infection can be exposed to what's named stress